Hyperthyroidism is a clinical condition in which there is excessive production of thyroid hormones, that is T3 and T4. There are quite a number of diseases which can produce hyperthyroidism. The most common being Graves' disease. Graves' disease is an autoimmune disorder in which B cells produce antibodies against thyroid proteins. One such antibody is thyroid stimulating immunoglobulin, which binds to the thyroid gland on TSH receptor, that is, the thyroid stimulating hormone receptor, which then cause the growth of the thyroid gland and release of excessive amount of thyroid hormones, the T3 and T4. Other diseases include toxic nodular goiter, in which follicular cells of the thyroid gland inappropriately produces excess amount of T3 and T4. Another one being hyperfunctioning thyroid adenoma. It is a benign tumor of the thyroid gland which again produce excessive amount of the thyroid hormone. Now, one condition is Jod-Basedow syndrome, which is iodine-induced thyrotoxicosis. Here, if iodine deficient person gets large dose of iodine, then he can develop thyrotoxicosis. Another condition is neonatal hyperthyroidism. This is seen in babies born of hyperthyroid mothers suffering from Graves' disease. The thyroid stimulating immunoglobulin crosses the placenta and reach the newborn, which in turn generates too much T3 and T4. Last but not the least on our list is inflammation or injury to the thyroid gland, which may then release excessive amounts of T3, T4, which are already stored in the thyroid gland. All these diseases are of the thyroid gland. There is another secondary hyperthyroidism which is seen in anterior pituitary tumor, which secretes excessive amounts of TSH, the thyroid stimulating hormone. Now, coming to the clinical features of hyperthyroidism, there is heat intolerance, sweating, warm, moist skin, hyperactivity, irritability, dysphoria, and tremor. Now, if we look at the ophthalmic signs, there can be lid lag, lid retraction, which gives a staring appearance of the patient, proptosis, periorbital edema, scleral injection, chemosis, or diplopia due to severe muscle swelling, and the most serious manifestation, compression of optic nerve. There is tachycardia, atrial fibrillation, and palpitation in the cardiovascular system, weight loss despite increased appetite, and diarrhea under the GI symptoms. Polyuria is usually seen, and in the musculoskeletal system, there is muscle weakness and proximal myopathy. Gynecomastia in males and oligomenorrhea in females, and loss of libido in both the sexes may also be seen. The treatment of hyperthyroidism includes antithyroid drugs, beta blockers, radioiodine, and subtotal or near total thyroidectomy, that is surgery, as the last resort. Of the antithyroid drugs, carbimazole or methimazole are preferred over propylthiouracil because of the hepatotoxicity of PTU. The use of PTU is restricted to first trimester pregnancy, thyroid storm, or in case of adverse reaction to methimazole. Propranolol or atenolol are used to correct the cardiovascular problems associated with hyperthyroidism. Radioiodine causes progressive destruction of the thyroid cells and can be used as initial treatment or for relapses after a trial of antithyroid drugs for at least a month before the radioiodine therapy is given. This is done to minimize the incidence of thyroid storm in patients who are treated with radioiodine. Pregnancy and breastfeeding are absolute contraindications to radioiodine treatment. Now, if the medications fail or to augment the outcome of treatment, subtotal or near total thyroidectomy may also be done in some patients. One more point to be noted is in case of primary cause of hyperthyroidism, that is, the basic pathology is in the thyroid gland, then the lab investigation will show a decrease in TSH level and an increase in free T3 and T4. However, if it is of a secondary cause like anterior pituitary tumor, then there may be a normal TSH level or a raised TSH level instead of a decreased TSH level commonly seen in Graves' disease and other thyroid gland diseases.